Okay, in previous videos, we talked about what diabetes is. We talked about the differences in DKA versus HHS. Now we're going to talk about some of the finer points of management, because although they're the same, they're actually quite different, and the things we'll focus on can be a little different. But the one overlying principle of it all, and I put it first, is I know we're going to see a sugar of 1200, and the first thing we're going to think is let's give them insulin. Unfortunately, if I drop your osmolality from 1000 blood sugar down to 100 immediately, all those little shriveled up neuron cells that had all their intercellular fluid pulled out because of such high osmolality, it's going to all go back in really quick. It can cause demyelination, it can cause seizures and even death, and especially in pediatric populations. If this is corrected fast, you'll kill your patient. You can do that in adults too. There's a little more give and take, but you shouldn't play it that way. You want to correct these things slow. So the first thing we start out, everybody has a volume deficit because they've had an osmotic diuresis. We start out with volume. So the first order you're going to see is like the doctor's going to want you to hang normal saline or half normal saline, and they're going to write an order for it, usually 250 mLs an hour. And you really want to first get that started before you do your insulin drip. Next, you're gonna have a BMP. That's how you're gonna find out they're there. So you're gonna find out, is this hyperosmolar syndrome? Is the person's CO2 low? Is it normal? Do they have a gap? They got a high on gap, I'm probably dealing with this. If I got a lower blood sugar, I'm probably dealing with this. If I got someone with serum ketones, urine ketones, I'm probably dealing with K for ketones, K for Kussmaul's respirations or Kussmaul's. So I need to think DKA. If I have a type 2 diabetic, if I got a really high sugar, I got a guy who doesn't seem to be very acidotic, but they can be confused from just that increased osmolality of their blood. I need to think HHS, but either one of them's got volume depletion. This one's got a very high volume depletion, up to 9 liters. This one can be up to 6. So either way, I start with volume. I want to give them that volume. I want to make sure their potassium's okay. If they're acidotic, like they can be in DKA, as the cell notices all these extra hydrogen ions floating around, what the cell will do is pull that hydrogen in. And to pull it in is a law of equal exchange. You're going to have a potassium ion kicked out. So now as I correct this acidosis in DKA, the potassium is going to go back in and the hydrogen is going to kick back out. So my potassium will rapidly drop, and insulin causes the cell to actually take in potassium as well. So that's why sometimes on your plan you'll see a potassium of 4.5 or 4, but they're telling you to go ahead and treat it. You're treating it to stay ahead of the curve, because as you start these insulin drips, the potassium is going to reduce. You'll usually see a basic metabolic panel ordered every 4 to 6 hours. So that's the reason we're doing this. We got to stay ahead of this, because you start treating this with the volume and the insulin, and their potassium's 4, you check it in 4 hours, and now their potassium's 2. So my question is, in either one of those, if you're running the treatment plan, which is all this volume, and you're giving them the insulin, and the potassium falls to a low number, the first thing you want to do is, insulin is your last priority, and it seems odd. Your first priority is volume and electrolytes. So you would, even if it's going to drop too much, you may stop this, talk to your physician or provider, and you're going to want to get their potassium replaced, because you can't afford to drop too low where you end up in arrhythmias, heart ends up paralyzed or in arrhythmia, and you end up in death. So that's why this electrolyte thing is so important. And sometimes people get confused. Why am I treating a potassium of 4? Their potassium isn't even low. I'm just going to let my DKA protocol run on. No, you don't want to do that. You want to stay on top of it because of this mechanism here. So what we look for in these is first volume, insulin, and keeping a close eye on electrolytes. And remember, if it comes between electrolytes or this insulin drip to keep running, you choose electrolytes and volume over everything. You're helping correct that severe degree of dehydration. Now with DKA, our big thing we look for is for that gap to close. Now that gap closing, if we remember that anion gap or high anion gap acidosis, means there's an unmeasured anion in there, which are those ketone bodies. That's those acetone and beta-hydroxybutyric acid. So as we switch from fatty metabolism back over to carbohydrate metabolism, that gap's going to close, because we're going to be doing things the proper way. The cell's going to be getting energy by utilizing carbohydrates. which is another reason when sugars get less than 250 or equal to it, you'll notice that we switch to D5 half or lactated ringer half. So the reason, that should be D5 half lactated ringer. I'm sorry. So the reason we switch over to this is we need to make sure we're giving their cells something to utilize as energy, because their bodies already use those fatty acids, the glucose is there, we've brought it down, but now we need the cells through the proper process to make energy through carbohydrate metabolism and to just do away and get rid of those free fatty acids floating around. So you're going to notice we're going to switch up from our half normal saline or whatever we have running the doctor chooses, or now a lot of people are going to lactated ringer to half LR. Even though it has potassium in it, can be a good thing here. Some people are worried it'll raise potassium. It actually doesn't. It brings you closer to the level of potassium in the bag. It doesn't add to another mechanism. We'll discuss in some physiology videos. But the main thing in HHS, that's the difference in here, is we're looking for that gap to close. We usually want 2 measurements 4 to 6 hours apart of it being closed before we give them coverage with a long-acting insulin, watch them for an hour, then take them off the drips. The gap is the big thing, and this one you'll have the physicians ask you, is there gap closed? Is there gap closed? That's what they mean there. And the other things, remember, fluid first. And when blood glucose equal to 250 or lower, you're going to start that D5 half or D5 half LR. With hyperosmolar hyperglycemic syndrome, we're looking at their osmolalities, the big thing, because they have these really high serum osmolalities. So with them, where we might drop them 100 milligrams per deciliter at a time, then we want to, 50 to 80 at a time every hour, and no more than that on the blood sugar drops. Sometimes we even slowly get them down to around 250 to 300 and let them hang there by titrating their insulin and their D5 half or LR half to let their sugar stay here for even up to 12 hours or more. Because if you shift that osmolality too quick, you swell the brain up and can cause seizures and death. And like I said, that's a real important point in pediatrics that you don't do that. So one other just useful clinical point before we close this, because we want to keep it as simple as possible, is a lot of times, especially in this, if you have this really high blood glucose, let's say you got one of 1,000, you'll get back your lab call for a critical on a sodium, and they'll say your sodium's 120. Now, this only works if your blood glucose is high. It's not because you're a diabetic. It's literally directly relational to how high this number is. You'll get a reduction in sodium. It's not a true reduction. What it is all that high osmolality and glucose outside the cell has pulled the intracellular volume out into that extracellular space, and it's causing what looks like hyponatremia, but it's a relative hyponatremia. It's almost similar to dilutional hyponatremia. But there's MD calcs online. There's a lot of good calculators you can use that are blood glucose sodium correction calculators. And you can plug in your glucose and plug in what your sodium is, and it'll tell you what your actual sodium is. Usually at around 1,000, your actual sodium's somewhere between 134 and 142. So if you wonder why, hey, I'm not managing this sodium, what's going on? The reason you're not managing it, as the blood glucose corrects, this auto corrects. So this is our education for CCRN interview on DKA versus HHS. I hope you enjoyed our videos and our content. If you could, hit like and subscribe, and hopefully soon we're going to have a lot more content available for you guys.